I've just got to stick it on record, guys. So.
Yeah, so set up private practice in 2012. Continued working with British Diving throughout that. So it's been about 16 years now. Been working through with them, and just expanded now to a couple of private practices. So for me, it's been a really good balance between sport and private practice. I actually quite like the two, as opposed to being fully immersed in either one. And just in terms of my practice, I've always been quite eclectic in my approach. I like to have my kits, so I've got my assessment kit, my treatment kits, and things. So in terms of assessments, I like to use motion sensors, force plates, handheld dynamometers, just to give a kind of a more objective outlook. And then in terms of treatment, I think I'd say probably the tech-out therapy is my go-to, because in terms of its versatility, but also when we've used blood flow restriction training for quite a while as well. So just combining those different things. Clinically, I use a wide range. I do needle as well. I do use what are they called? Tools, yeah. And so I think that the key really is just being able to combine those in my practice. Because really, I've always sometimes it's the integration of all of those things, as opposed to just the dependence of one of those that gives you the best effects. So started with Paul. I think maybe it's now going on 4 years now. I think
4 years. Yeah, 4 years.
Yeah. So yeah. So I've been using tech-out therapy since then, and for the past year, been doing some work just on the international academy side with Winback as well, which has been a great experience, and actually just looking to see how Winback is being used, in the different countries as well, and the challenges that they're facing in terms of clinical. So it's really given me a very good outlook, really, in terms of not only where Winback is going and how they're really working with clinicians to improve the products and improve their market presence, but also just how tech-out therapy is really being advanced and progressed on a worldwide level.
Thank you very much. Cheers. Mickey, do you want to do a sort of background intro to yourself?
Yep. I'm an osteopath. It was a late career change. So I was 32 and went back to uni part-time for 5 years, over back to Keele and then Staffordshire University, and I qualified with the College of Osteopaths in 2015. And about a year and a half later, I got to do some part-time work with Team Sky, professional cycling team, and then I eventually went full-time, and we have 6 seasons done now with the team. I've taken over as head of therapy this year as well. So we've got 3 full-time therapists and 2 part-time. We've got 2 full-time physios and 2 part-time physios working alongside us. We've been using different type of tech-out therapy for the last 6 years. And we've had some really good outcomes with it. So we thought with the Winback there was a lot more academic information along with it. So we've went ahead with 2 1Ss for next season.
Fantastic, good stuff. Thanks, Mickey. And you're also working in when you're not with a team, you're doing private practice. Yeah,
I'm like Gareth, combining the 2 when I can.
Fantastic, good stuff. Appreciate that, Brendan. Well, just all about background about your practice and your history and experience so far.
Okay, so I'm a physical therapist. I suppose I'm in the business maybe 17 years at this stage. I worked with Irish Paralympics for 4 years during the Beijing era. I'm since then based in private practice like what Gareth spoke about, it's about integration. I use MLS laser shockwave needling, and I suppose this was the natural extension of that, using the TCAR, and I just want to, I suppose, increase my hit rate with improvement to patients by a couple more percent, and it seems to be doing that just at the moment, and people like the treatment of it so far. So I'm practically using it with most people, except sometimes people come in with a long list of injuries, and I find it's just easier to go back to what I know as opposed to using the TCAR on it.
Okay.
Where I am at the moment.
Thanks very much, Brandon. I think it's about 5 months now that you've had the system.
Yeah, it's about that. Yeah,
more or less. That's great stuff. Fantastic. David, can you hear us? Are you able to get on your screen, or are we able to see you? Same with Adrian and Kofo.
Yeah, I can hear you guys now. My screen's a bit off here at the moment. I'm just getting fixed up here. Good morning to everybody. How are you?
Good morning.
Good morning.
Morning, Kofo. Thanks for coming live. Up to you in a minute. We'll just do a general intros here as we bring people in. We'll get moving in a second. David, do you want to just give everybody a little bit of background to you and your kind of professional background, and then how you've been working with Winback as well, please?
Yeah, absolutely. So I've been with Winback, a couple of years now, I think, Paul, isn't it? It's a good bit now, I think.
4.
I was quite interested early. 4 now, isn't that it? Woof, that means I'm getting older, unfortunately. That's the worst thing about it. But me, myself, I suppose, my background, I suppose, is I did my BSc initially in sports rehabilitation. I went along and did my postgrad in sports and exercise with a big drive towards movement, which becomes more prevalent with Winback in a moment. I then did my master's in sports medicine in Cardiff, and then I moved home, set up my own practice in Kilkenny here with one person, just me, 10 patients a week. We've grown that now to 2 clinics, 8 staff, 2 Winback machines. Do my PhD at the moment in Limerick in around human innovations and injury rehabilitation as well. So the ability to make sure our patients and our clients are, when they get injured, back on the pitch quicker with the least amount of performance lost. And that's probably why I was so attracted to Winback. Winback has obviously the ability to use and mix hands-on skills and hands-off skills. A big thing in physio when I qualified first, I think, was, and physical therapy and all that stuff, was hands-off versus hands-on treatments. Some clinics are hands-off, some clinics are hands-on. I thought with Winback you could marry both. And as you can kind of tell, a lot of my clients I work with movement-based too, because I believe movement is the function of absolutely everything. So with the hands-off version of Winback, it allows me to be able to treat patients and treat the system and treat the condition and treat the joint at the same time. So for me, I was absolutely intrigued, and I've been very lucky to have, world champions, Olympic champions, international sprinters, Adidas runners, Nike cross-country athletes come visit me here in Kilkenny, and every one of those guys have been exposed to Winback and have loved it. So for me, it's been brilliant. I bought a second one then because my staff were annoying me to use it. So I'm probably going to be getting another one, I think, when we move to our brand new clinic. We're building a brand new clinic here in Kilkenny in Ireland in the next 2 years. I'll probably be reimbursing and making sure the clinic is fully equipped in that respect there as well. So that's a small bit about how I do and how I use it. It's a great piece of kit. Yeah.
Thanks, David. Cheers. Kofo, thanks for coming online now. Do you want to just give us a little bit of background on yourself, where you're based, kind of practice you're in, bit of your background, and what kind of patient profiles are you looking at?
Morning, everyone. Sorry that I joined late. Hi, Paul. Thank you so much. And Kristen, thanks so much for bringing me on. My name is Kofo. I'm originally from Nigeria. I trained in Nigeria. Then I went over to Republic of Ireland in Dublin. I worked there for about 10 years, then moved over to the UK. I'm a physiotherapist. I had my MBA in health management in Dublin, UCD. Then moved over, did my BOBA training, stayed in the UK for a while. Then, pain of wanting to start your own practice. I've been in practice for the past 23 years. Then moved over to Nigeria to start off because it was a calling that I went back there and started a rehabilitation center. Normally I go for I travel back to the UK to do some of the assistive technologies and all that. So I met Kristen at one of the programs in Birmingham. Yeah, I'm very new. I'm very new when it comes to Winback. I'm trying to get the government to buy into it. I was part of WHO nominated people for development of wheelchair education package, which has just recently been launched. So I'm really looking into government because obviously rehabilitation is a massive involvement and investment. And Africa.
I'm just, I've got the power of muting. Sorry, Ashwell, but
yeah.
I love your family, but yeah, keep going.
Yeah, so Africa is a virgin land, is an unmet, with massive unmet needs. The money is there. It's just getting the right equipment. So I'm very new to Winback. It's something I want to push. It's something I want to push nationally, not just in terms of just my clinic. So it's unfortunately right now things are a little bit political wise, a little bit upside down. Yeah, so we are still in the process. So hopefully at some stage I'll have it in my clinic so that it will convince them how much it works. I have my clinic, I have 8 physios. I have 3 occupational therapists, speech and language therapists. It's a complete multidisciplinary team. I do have some consultants that will come in to consult with the patient. We have inpatient and outpatient in the clinic. And basically it's all about rehabilitation, especially patients with spinal cord injury, road traffic accident that are just really looking for rehabilitation.
Great. Okay, that's a great story. Thank you for sharing that.
Thank you.
And then we got one more person joined. Ashwell, can you just give us a little bit of background on yourself, where you're based, your own personal background, and then we'll dive into what we're going to be talking about today.
Hello. Sorry, maybe I disturbed you when I joined in the first time.
No problem.
I'm sorry, there was some background noise. The kids were making noise. I'm a physiotherapist in Namibia.
Okay.
But I'm from Zimbabwe originally.
Okay. Right. Okay. Sorry, carry on, Ashwell.
Okay, what else do you want to know?
Just give us a little bit of profile of the kind of patients that you're dealing with.
Okay. So I'm sort of I'm in charge of 3 hospitals in Namibia. So it's a region. It's called Oshikoto region. So I'm the senior physiotherapist there. Because of some logistics, I'm working in one of those hospitals. I'm covering a whole hospital alone. I mainly cover outpatients and inpatients. And then sometimes I do community work, maybe once a month. I go to the communities to screen some patients, and then maybe refer them if there's a need. I think that's all.
Okay, well, that's great. If we could just get you to pop yourself on mute,
okay,
so we don't get the background noise. That's fantastic. Well, listen, to Kofo and Ashwell, I know you probably need more of the background to Winback, so we're gonna sort of send you the slides on that, because the group we've got on here are kind of, let me say, much more experience in terms of their use. We wanted to make sure they got some information around the questions and areas that they have. So why don't we, and David, just from your side, so this session here, rather than going through all the slides, because the majority of people on the call kind of know the theory, know the science. There's more an opportunity now for Brendan and Mickey really to sort of let's tease out the areas that you want Gareth to focus on in the next 45 minutes to an hour or so. So, Brendan, can I get you to kick off, because obviously you've logged some questions here, but why don't you just walk us through those questions, and we'll get Gareth and others to kind of respond as well.
Okay, I suppose my first one was there with regard to was with regard to the return plate and the active plate. Is that the closer they are together, the more benefits or the more beneficial it is to the injury that you're dealing with?
Yeah, so I think the thing to always try and remember when you're talking up the positioning of the return plate is one, the actual area that you're trying to treat. So, for example, if I'm trying to treat the hamstring or the quads, really I want to have the return plate and the active electrode on on either side of that, maybe initially if I'm on the RET mode. And the idea being you're trying to increase cellular metabolism throughout the entire muscle group rather than just a local aspect. So sometimes if I'm doing, let's say, sciatica, and you actually want to use the, maybe to work on the whole nerve as opposed to a segment of it, again, you're from the foot all the way up to the low back. So I'd say the first thing is that it depends on what area that you're trying to treat. In terms of the theory, yes, the closer the plate, and the active electrode is, then it does mean that the path that the current has to flow is much less. So what you'll find invariably is that you need to reduce the intensity with which you're treating, because if you have it too high, just the path of the current is a little short, and then actually you get a much increased effect. So
can you see that screen, Gareth?
Yeah. So you can use that. For example, if you're trying to work, let's say, an effusion in the knee, and you're just going to have your, let's say, your mobile electrodes just on either side of the knee. So it's a very short kind of distance. But if you're looking, let's say, it's a good example that's up on screen. It's not only how close the electrodes are, it's also what side. So if you have the electrodes ipsilateral, so on the same side together, you've got more of a, let's say, a superficial effect. But also, and again, using the knee as an example, if you're working on patellofemoral joint pain, you've got that just above the knee, over, let's say, around just over the quadriceps tendon, and then just below the knee, just kind of over tibialis anterior, the proximal third, and the current would be going through just under, literally just underneath the patellofemoral joint. So so to summarize, the closer the electrodes are, actually you get, there's less distance for the current to travel. So therefore you get a more concentrated effect. You have to reduce your intensity as a result. We're talking a little bit about the back four later, but one of the things that the back four does is that you don't have to change the intensity, whether your electrodes are close together or whether they're far. The back four will automatically, if you were to set 40%, where however far apart the electrodes are, it would determine that 40% would be done that way. So in the back four, that's not going to be so much of a concern as to the distance between the electrodes. But if we're using the back 3 and the back 1, like I've got, then yes, the distance does make a difference. And so if I'm using, let's say, the electrodes further apart, I tend to use an intensity maybe 50 or 60%, just to try and get the same effect.
Okay. Let me just see if there's any other. Yeah, I just brought those up because I thought they were.
Yeah.
So, Brandon, your next question. So, does that answer your first question? Sorry.
Yeah, it did. Yeah, perfect. Yeah. Now, the next one is are there more benefits to actively and passively moving of the joint as opposed to leaving the patient static when treating?
So yeah, the answer to that is 100%. There is a lot more benefit, and the reason for that is the way your resistive electrodes are going to work. So what we're doing is your resistive electrode is targeting the tissue that has the most resistance in it. So the more resistance is in the tissue, you kind of get the effect around that. So if you're getting a muscle contraction, for example, the bunching of the tissue increases the resistance in the tissue. And what you do then is you localize the effect of the TECA to where there's an increase in the resistance. So if I'm doing a biceps curl, or I'm doing plantar flexion, dorsiflexion, any kind of movement that's going to generate, number one, an increase in the muscle tension is going to allow you to further target the effect of TECA therapy specifically to the muscles that you're trying to contract. When it comes to the joint, what we know is that when a joint moves closer, let's say to the close pack position, the resistance is increased in that position. So again, you target the joint. If you've got let's say a return plate and the other electrode on either side of the joint, if the joint is the one which is doing the moving, whether it's passive or active movement, just the movement into close pack or open type positions means you're varying the resistance there. And actually, you would specifically target that area. So you can do it passive. And if you did it, if you were doing a passive version of a treatment, then you're targeting either the whole chain that you've got, or if it's very localized, like say using the CET or one of the, particularly the CET head, you're just using in that particular area. So with the CET electrode, there's no particular benefit to moving or staying still. But when you're using RET, the increase in the resistance is going to target the TECA therapy to the tissues that have increased resistance.
And let's say, how would you put that into effect with something like a nerve root pathology on your lumbar spine with active movements? What way would you do that?
So if it's either going to be with joint mobilization, if it's in the lumbar spine, it's either mobilization, or again it might be proximal. It could be a proximal. So even if I was doing, let's say, like neural gliders and sliders, but you're actually targeting more the proximal chain, getting posterior pelvic tilt, anterior pelvic tilt around there. So any kind of movement which is going to either allow a stretching or a gliding of the nerve tissue, particularly in the muscle around that, actually would give you the same effect. So again, you'd be treating the first and then the important thing is that you'd be treating the nerve tissue the way you'd normally do that. So if it's discogenic and you're doing the mobilization, the joint either with the bracelets or even just with the sticky electrode above and below, and you're doing the mobilization. But just the mobilization where you're pushing through the joint, creating a bit more tension and compression around there would target that particular joint while you're doing your mobilization. But again, any movement, so let's say it was anterior posterior pelvic tilt, and even if you're doing that in supine, again with the electrodes, that would still work. You could target. What I tend to do is just is to use the sticky pads, and I'll probably have it somewhere around the T12 maybe to about T8, somewhere around there, and then the second electrode over the glutes and proximal hamstring when I'm doing that kind of exercise, and then I'm targeting just with either rotations or anterior posterior pelvic tilts to try and settle the muscle and the tissue, or to get a little bit of proximal nerve gliding. That's how I would do it.
Brendan, if you, thanks for that. If you just hang on a second, what I'm going to try and do is show you a little video that sort of demonstrates that. So if you bear with me, Saturday morning and all that kind of stuff, see if I can get this up. I think I can share this. Can you see that, guys?
Yeah.
Yeah.
Let me see if we can do it. So, it's to some of the points you were talking about, Gareth. I think this covers a little bit. But what I'll do is make sure I'll drop this video. So in this clip I'm going to show you, you may have had this before, but you may have overloaded with information, so you may not have got to it. But what I'll send you and drop into the sort of chat box is there's kind of about 15 different pathologies, little video instructional guidelines that are designed for you, the therapist, just to give you some orientation around clinical reasoning and then how to. So if you bear with me on this one, hopefully you can see that. You see that okay?
Yeah.
Yep.
Yeah.
It sort of bobs out, it tilts.
Yeah.
So that one there is worth talking a little bit about, Gareth, where you've got the return plate under the abdomen and the sticky resistive plate on the back. Is it worth just chatting that one through? Is that something you've used?
Yeah, so I think the positioning of the two electrodes makes a big difference. I think in this case, it's probably trying to target the segments right through the spine. So you'd have the return plate below and above. But as I was saying before, just the movement, particularly now coming into extension, and you're increasing the resistance of, or by actually your facet joints are now coming into a close back position. That increases the resistance. You're able to target those joints in particular, and particularly there's ones which are fairly stiff anyway, and there's some kind of pain. We know, yes, you're targeting, the disc as well in that position, just doing the extensions. So that's maybe a setup I would use specifically for facet joint and for discogenic pain, where I'm actually wanting to go right through to the segment. And obviously with the return plate now being on the abdomen, it's going to target all the tissue through the abdomen between the return plate and the sticky electrode. The movement helps you to actually direct the current and the flow of the current just to the segments that you're wanting to work on. In this case, the spine and the disc. If I was actually wanting to do it more from a nerve and a neuro point of view, I'd have maybe the return plate either on the hamstring or on the calf, depending where I wanted to target, and then perhaps do something like a straight leg raise or neurogliders in that way.
Okay, that's great. Let me just keep going.
Yeah.
Apologies for the music. No, I got rid of the music. Stop me at any point, Gareth, if you want to add anything in here. Maybe this one here, this pelvic of glutes as well.
This is one I've used actually a lot for let's say initially for high hamstring pathologies. And so especially when you're just looking at attachments, anytime like avulsions or any kind of tendinopathies, and you're doing a posterior pelvic tilt and the bridging, particularly when you start doing the isometrics and you're trying to load isometrically on the one side, it's going to be a little bit sore. Actually having the return, so in this case I'll probably have the return plates over the lower back and maybe just on the hamstring to do it that way. But if we're talking about in this case chronic low back pain, it's I've had the return plate on the abdomen as you see there, and you can either have it just underneath in the back, but because you're also trying to get gluteal muscle contraction, sometimes it's better to have the other electrode more over the proximal hamstring. So it's not a matter of just targeting the painful area in the low back, but also the muscles that you're trying to activate. Because particularly if patients are struggling to activate glute max going into the bridge, you want to have the TECA therapy actually just helping to increase cellular metabolism and improve the neuromuscular coordination.
So why would you put it on the abdomen there? I didn't quite get that.
You've just got it on because again, if you're trying to target the spine and you want to go through the whole spine, you need to have something which is above the spine and below the spine. So in this case, you're looking at chronic low back pain. The other thing, with chronic low back pain, which is really particularly beneficial to have the return plate on the front, is actually you're targeting your psoas muscle groups as well, which quite a lot of the time, because of the attachments onto the spine, are indicated, particularly when you're doing, let's say, your bridges in this case, and trying to maybe activate the muscles working in opposition to like the glutes. Quite often for me, in that position, I'd also switch to having bracelets and actually work on psoas, do kind of psoas muscle releases in that position as well.
I think in this case here, I don't know if you can see my pointer, but where she has the return plate is on the back of the calf, so she activate the whole chain, if you like.
The whole chain, yeah.
But as Gareth says, but you equally, it's finding the right approach that works for you. But that whole clinical reasoning at the beginning drives everything. So we just play forward. Stop me.
I can stop on that one actually. So in this one, we're taking kind of your traditional exercise here. We're saying we want to target the glutes, and in this case, yes, you're targeting the active segments on the left side, but quite often when I'm doing fire hydrants, I'm quite often targeting maybe the close chain on the other side, just trying to stimulate that. So you could have exactly the same exercise, but actually have the return plate and an active electrode on the other side if you're trying to target more close chain side in terms of gluteus medius activation, or open chain as is got it on that side. But in this case, yes, because it's open chain and it's on either side, the movement and the contraction of the muscle actually would then target gluteus medius and tensor fascial lata as well in that position. If you were to put the, so just have it exactly the same setup in terms of the exercise, but have it on the other side. Gluteus medius is probably working in its more normal capacity on the closed chain side, but because now it's constantly under load and tension while you're doing the exercise, it would heat up really quickly. So actually the only difference between the two is I might have a slightly lower intense, or just put it on low pulse. So while if I had it on 40% while I'm doing, I'll just put it on low pulse, just because that gluteus medius muscle is constantly under tension while you're doing the fire hydrant on, let's say on the weight bearing side. And then that would just ensure that for the duration of the exercise, it's being targeted, but it's not going to heat up excessively.
Okay. Brandon, okay for you?
Yeah, very good, yeah.
I'll just play it on. Stop me again. I think
yeah, it's just similar. Yeah, so again, yeah, so this is this is an example where sometimes you can play with the position of the electrode. By the time you're doing core strengthening, really, and in this one, you know, TA activation, maybe you're trying to focus on also lower ab recruitment. So a better position for that might be to have, instead of the plate on the calf, it might be on the top of the on top of the quads. So then you're targeting, you know, the hip joints, the lower abs, particularly if you've got the return plate underneath the back, that would work well.
Yeah, I think on this example, the return plate is on the back.
Yeah, that's right. Yeah.
Want to tell this one through?
All right, so this is one of my favorite ones to do, actually. So I either do kettlebell, so I use kettlebells quite a lot. So we're doing either squats, goblet squats, kettlebell deadlifts, for example, and just basic movement patterns that you're looking at. So there's two things with that. One, it's pain relief. So if there's pain when we're doing those movements, I might start off with a very kind of small range movement, and as the pain improves, we start to increase the range in terms of where they're getting to. Also, I'm looking at the point at which the movement is going to break down. So where they've got good technique through the movement is kind of where would stay around there. And then this will probably for me be like in an earlier stage of rehab, where it's just got a couple of dumbbells, or you're doing it body weights because you're just starting to reintroduce that type of movement. You're thinking there might be pain during the movement, might be a little stiff and sore once they get started. The takeout therapy just helps actually to activate the muscle, to increase the metabolism, reduce the pain, increase the circulation, but also that warmth is a comfortable feeling, something for them to focus on while they're doing the movement. I'm also thinking that one of the effects of takeout therapy is that it lasts for about 24 hours afterwards. So after doing the exercise, where you might get a bit of soreness because you've just pushed that exercise on, that might be the first day he's doing this kind of a movement. You're thinking 24, I want that increased circulation, that increased metabolism and pain relief to last beyond the exercise. So actually, you've got three possible roles there. You've got a warm up you can use it during the exercise, and then you've got a recovery kind of function afterwards. So you can combine all three just with the movement. So in this example, again, it could be looking at either, yes, it's low back, or it's glutes, or it's high hamstring. kind of strain. This is probably more of a setup for a high hamstring strain in this one, and you're just starting to start loading the hamstrings again from that point of view. So actually, one of the things that I've noticed that I can push patients slightly harder in a clinical setting. We tend to do that anyway when we're supervising, but with Tekhan in the early stages of rehab, you can push them a little bit harder because of the pain relief effects that you get with the Tekhan therapy, and the fact that once they're going to leave, you can rely on the fact that it would still, the increased cellular metabolism would help with recovery as well.
So, sorry, just in case it wasn't abundantly clear. Yeah. Obviously, the foot, the return plate is under the foot. Yeah. I'm sure everybody picked that up. Maybe Gareth, this is a nice schematic of how the different kind of accessories are used. Maybe just walk through that.
Yeah. Okay, so so let's focus from the CET forward, just because with the back ones you're not going to have the mix and the mix plus. But we know that two key frequencies that you're using with the CET and the RET, 500 and the 300 kilohertz. So
can I just stop you there for 1 second? Just for your information, Mickey, the systems that you have at INEOS, I don't know why it happened, but your luck is in that you do have the setting on Mix and Mix Plus.
All right.
These superficial devices, these handheld devices here, we could talk to you about that offline, but you have got that function to work more superficially with the tripolar ones. You won't have seen those yet. I think you may have them on your Bank 3, but they could be available to the INEOS team. So maybe just touch on that, Gary.
Yeah, no, let me start with those. So one of the key innovations with Winback was when we're using CET and RET, we always have to have the return plate and the electrode. So one of the innovations, one either for a very quick application of Tekhan therapy, or when you're using a very superficial, so think of scar tissue, think of hematomas that are maybe not so deep. Think of, let's say, like TMJ, when you're trying to work on something like that. It's not so deep. One of the innovations they had was to create, it looks like a probe with just 3 points on it. And what they've managed to do is to incorporate the return plate and the electrode all on the same probe. So the current basically is flowing just between the little electrodes that are on there. So you don't need a return plate. Everything is contained within the probe. So it is very quick. It's very easy to apply. It does give maybe about 50% of the energy that the others would generate, just because of the distance between the small electrodes there. I remember when we're talking about the distance that the current has to travel, you can't have a high intensity. So what they've done to compensate is just that they've reduced the power which comes through that particular probe, just because of the proximity of the probes to each other. But what it does mean is that if you are wanting to work on scar tissue post-surgery, if you want to work on really superficial tissue, and particularly in the beauty department, that's a go-to. But it also provides the third frequency, the 1000 kilohertz, which is for very, very superficial tissue. But it also has, let's say, for the subcutaneous tissue, you've still got the 500 kilohertz, which is the mix plus. So now moving on to the other two, which are just going to operate at 500 kilohertz and 300 kilohertz. So in particularly in terms of the CET head, the important thing is really understanding how that CET actually is generated. So in short, yes, the word is capacitive electrode. And the main thing is the coating, the black coating actually is a resistant material, which is on there. What it does, it's going to trap the energy and then it's going to release it as a packet. So that case, it means you're not going to penetrate as deep, but you're going to have a more concentrated effect over a shorter distance. So in the just your normal CET, you'll penetrate 2 to 3 centimeters below the surface of the skin. And one of the reasons why you have to keep moving it is because it's storing that energy and releasing it as small packets quite regularly. The tissue is going to build up in heat really quickly. So you'll know that if you're using the CET, that tends to warm up a little bit more than if you're using the deep CET, for instance. And that's only because that packet of energy has got to travel a little bit further. And so it's spread out over the area that it's traveling. So when we switch to deep CET, you can go to 4 to 5 centimeters below, the surface of the skin. So, for example, as you can see, actually in that example, if I'm trying to maybe target the muscular tendinous junction in the quads, I might use CT. But if I'm actually wanting to target vastus intermedius and the tissue below that, then really I want to look at deep CT. And as an example, I have to say what I said to Paul at the very beginning when we first took Winback on. I said, I had the demonstrations and everything. And then I said to him, well, listen, I'm going to bring a complicated case that we've had. And if it works, then I'll take it. And it happened to be a diver who'd had like chronic, like just cramping in the quads, and we couldn't figure out, she had blood tests, we'd looked at neural work, we'd looked at offloading, offloading completely, but just for some reason was cramping a lot. And we did like 2 or 3 treatments, but mostly just using the deep CET mode. And really quite was dramatic, the improvement in that, after which she never had any cramps again, and we never actually had a problem with it. But I think one of the key things was the ability for this particular frequency to target the deep tissue and just to start generating a bit of circulation in that area, and maybe just reducing the resting muscle tension to allow her to be able to train without always going into a spasm. So that setting is really quite useful for targeting the deeper muscle tissue. If we move on to the RET, and just a quick reminder that it's that doesn't have any coating on it, so it's the silver electrode. So that allows the current just to flow continuously between the 2 plates. So we've got 3 versions. Actually, there's a few more different modes of application. But if we're looking in this case, we've got the actual electrode, and you've got the 500 and the deeper one at 300 kilohertz. Now, the key thing with the RET to bear in mind is that you're not only targeting the depth of the tissue, but you're also targeting the type of the tissue. So the 500 kilohertz will kind of target more the tissue which has a higher water content. So you're looking at your muscle in particular. But if you're thinking of, let's say, joints, ligaments, joint capsule, those kind of tissues have a lower water content, you really want to use your RET plus. And that targets kind of your tissue, which is non-contractile. So going back to your original question, Brendan, about about movement as well. If it's the joint that you're trying to target and you're doing active passive movement through the joint, you want to be using RET plus. But if it's muscular contraction that you're trying to generate, let's say you're looking at the muscle, the muscular tendinous junction, then you want to be using the RET with the movement. Then your last mode of application is just with the bracelet. And again, if you're doing joint mobilizations or you're kind of working around the joints, you've got the bracelet on, but you really want to focus on either your RET or RET plus. If I'm doing joint mobilizations, I've always got it on RET plus on the machine. If I'm just doing typically soft tissue work around the muscle, then I've got it on RET. You don't feel the difference in terms of wearing the bracelet. And it's actually quite interesting that when you're looking at thermal imaging, when you've got the bracelet on, although the heat on the thermal image is actually at the point of contact that you make with the skin. And actually the distance between the area between the bracelet and the point of contact on the thermal imaging actually comes out as normal. So it's quite an interesting thing to see.
That's great, Gareth. Fantastic. So, Brandon, let's carry on with your next question. You got another couple, and then we'll go to Mickey and get some insights from Mickey.
Okay, I think you've answered kind of the next couple, but I just when we were talking there, a couple of things came up. Optimal number of treatments per week. I know you can do it every couple of hours if you want to, but that's not practical. But like the minimum amount you need to do per week to get the maximum amount of results.
So I think that the good thing with tech out there is you'll see that you start to get results immediately, with it. So in terms of pain relief, for example, it's pretty much immediate. So when I'm getting really chronic, complex, type patients, it's pretty immediate. And that's one of my go-tos. But in terms, I guess that the way I would answer that question is what I'm trying to target, because I wouldn't necessarily base the number of times I see a patient on the need to use Winback. It's more about what do I need in order to achieve the goals and the targets I have for that particular condition. So in my clinic, I have a system. Maybe a different model that I've tried to adapt from what we use in elite sport, where in elite sport we're not concerned about how many times we see patients. We're just concerned about the outcomes. So we can see them an unlimited number of times. So I've adapted that to have a kind of subscription model in my clinic where, yes, for 2 weeks, 6 weeks, or 3 months, they'll come for an unlimited number of times. So if I need to see patients every day, I'll see them every day, particularly if there's a setback in the rehab process and we need to see them more often than I would. It allows me to plan, my sessions a lot more, so I can have maybe a testing session at the end of the week, or if it's, post-op and we need to get a lot more movement and pain relief and try to start getting, basic muscle activation. I'll probably see those a lot more often, and then as things get better, I'll drop off in terms of the number of sessions that I'll see. So typically, if there's a lot of pain, there's a lot of stiffness, and so let's say post ankle surgery, and there's just a lot of stiffness in the ankle. Actually, I'm having the patients coming in every day so that I can work on that. But maybe that starts to drop off. So that's more tied up with what I'm trying to achieve overall with the patient, as opposed to say I need to use Winback 3 or 4 times a week in order to achieve the effect, because my treatments are always compound. So I'm using a number of things. So in your case, where you've got a number of different types of equipment, I'd always recommend combination therapy, just combining a couple of the different modalities together with the Winback to achieve maximum effect.
Brandon, any more Q&A from your side?
And I suppose, lastly, there with your older arthritic neck patient, how do you approach them?
Yeah, really good one. So typically, my go-to is either having the return plate or the sticky electrodes somewhere around T8 and below. So maybe around T8. And the reason I have it there, because quite often, you know, we do consider functionally the upper thoracic spine to be functionally affecting what happens in the neck as well. So whether it's looking at the musculature, that really allows me to target the whole segment, let's say from C0 to about T7. Also allows me to target the musculature if I'm looking at the mid-traps, the rhomboids, and looking at paraspinal neck muscles as well with that. And I prefer the sticky one because at some stage I'm going to turn them over, or I'm going to have them like, well, could have them on the side, could have them on the back. And if I'm starting off really lying supine, I don't tend to have to go through the neck. I tend to have it on the T-spine, as I said, and then initially just using CET, and I tend to use the deep CET actually if it's a lot of OA and things like that, because I really want to target very deep the tissue quite deep through them. So I'll start off with that, and maybe a little bit of soft tissue or the RET, and just use the slightly smaller electrode as opposed to the big one as well. And then I'll turn over onto the back for what you see is the setup that you've got there. The really arthritic necks sometimes, and the older patients, they tend to need a couple of pillows under the neck as well. And then I'm just working with the bracelets on both my hands to do a combination of traction and soft tissue with that, and also kind of movements with mobilization. So a lot of rotation and kind of flexion, extension, and maybe a C0, C1 kind of movements as well. And the idea just being, again, with my hands around there, just trying to target specific segments or muscle tissue as I'm working through that. So that becomes quite an important, it's just the use of the bracelet. As you'll know, when you're using the bracelets, if you've got it on both sides, you're splitting the energy between the two. One of the things just to say about back four when it comes up, because it's got two motors and two generators within the unit. If you have a bracelet on either side, you're getting 100% of the energy on either side. So actually it would be a lot more effective from that point of view as well.
Okay, and just let's say, how do you deal with somebody who comes in? I know you'd be looking at other areas, but somebody comes in with a bilateral chronic Achilles tendinopathy. Do you just treat one, or do you treat both, or what way do you approach it?
Yeah, so the answer is I've actually done both. Sometimes I'm really wanting to, by the time I've assessed both, and I'll start maybe working on one particular, let's say if I'm wanting to release the deep tissue, like soleus, wanting to do ankle joint mobilization or manipulation, or just doing the active exercises. Or sometimes I might work on one versus the other, particularly if, even though it's bilateral, there are some things which are peculiar to each that I want to target on. So that is, But quite often when we get to the stage where actually I'm starting now to start with the exercise, and typically the exercise and doing it bilateral because it's too much to load unilaterally. Then I'll be doing that. I'll be doing that with both. From that point of view, I'd have the bracelets just under on both feet, and then you can have the return plates higher up in the back. Or what you can do, and what I have done is, even though I've got the bracelets on both sides, I might have a sticky or one of the wraps on the one side, just to start that process, and then the next set switch it to the other side so that it's already connected, and then I'm focusing on that side while they're doing the bilateral. So some was also quite useful doing it on a bike as a warm-up as well. Just get them to turn over. So if I'm trying to just warm up the lane again, I've got the return plate on the back, and then the two the bracelets on the foot while we're doing that. So although I think the key thing to remember, with that, is if you have it that far apart and it's bracelets, you have to just increase the intensity and maybe take a little bit longer. So you're looking at maybe like a 50 to 60% on that.
Okay.
Yeah.
Brilliant. So hopefully that gives you a little bit more progression just in terms of understanding as well. So Mickey, from your side, I mean, Q&A sort of thoughts, areas you want to sort of dive into particular.
Yeah. Like Brendan, I haven't got my homework done. It was more just the practical applications of the accessories. Where, like as Garrett's saying, putting the bracelets around the feet and like a return wrap around the leg. It's just learning those processes for us, because historically we would have just had the Indiba and we would have treated the athletes statically. So it's just learning all those tricks and tips, I suppose. But I think with all the YouTube videos, we can pick it up pretty quickly.
Yeah.
I mean, one of the thoughts we can do is when you have your training camp in Alcudia, if you wanted a session with yourself and Nathan and any of the other therapists, and I'm just throwing this out here, the night before, or when you guys get in, got all your kit sorted out, everything ready. If you want us to arrange a session, it may not be Gareth, maybe somebody else, but more than happy to kind of do a coaching session. Once you get to Alcudia, if that makes sense. I know you'll be in a pressurized environment, but
it'll just depend, because we've got some physios coming in and out, so I don't think all of us are going to be there at the same time. And it's going to be in January because everybody's spread out.
Yeah, you can video it. It's probably the most useful, and then it's available for the others to see as well.
Yeah, I mean, we can if this makes sense for you. What we've done with Andy Murray as an example. So his two physios plus Angela both have a WhatsApp private group. So whenever they've got an issue, right? So I don't know, somebody comes off the bike, somebody also, you got a go-to place that basically says, look, got an issue, here it is quickly, it's all confidential. Any advice, tips, you may never use it, but you may want to have it just as a backup. We can set it up for you and Nathan, Mickey, and then you just use that as a call for help.
Yeah, that'd be good.
That makes sense?
Yep.
One thought, Gareth, I thought might be interesting for Mickey to hear is some of the in competition stuff you've been doing, because you've been particularly on things like BFR and warm-ups and some of the hacks, and I'm only thinking, I know in your environment you don't want to, it's so rigid, you don't want to introduce anything that might cause another thought to enter the athlete's head, but I thought it'd be quite interesting for Gareth just to share some things you've been doing in competition.
Oh yeah. So on a wider level, I guess the key things around load management, and that's, you know, if we're really talking about the athletes, it's all about managing load. And I think looking to see what are the things that we can do, one, to reduce the load, but to maintain peak conditioning, to encourage, to optimize actually maybe for competition and for them to compete at an optimal level. Just bearing in mind that the nature of sport is repetition. They're going to be repeating the same movements. So we're really trying to look at once we understand the movements they need to do to optimize those. And then the third principle in sport is always about recovery. Can we get them to recover as quickly? And, you know, we talk of recovery starting immediately as soon as they finish, and the whole process and the things that they're going to do with that. So in terms of load management, one of the things that we were looking at, say, you know, diving is a very technical sport, but even in it really applies to any sport, is that role between how much strength and conditioning you're going to do and how much you're going to train. So one of the things we started looking at was was there a way to reduce the overall load, but maintain that level of conditioning. And for us, we started using a lot of blood flow restriction training. Typically, it had been used in rehab. We use it in rehab. We know we can't introduce a lot of load. It's painful, or the muscle isn't strong enough, or the stage of, let's say, post-surgery doesn't preclude that. But this is a way of maximizing the strength gains. But actually transferring that into strength and conditioning kind of an environment where instead of squatting, you know, 100 kilos today, they're going to squat 40 kilos, but they've got the BFR, and they're going to still have the same effect as squatting 100 kilos. That became quite so something we started introducing, you know, a couple times a week now, actually. But when it came to the competition, and we're looking at post-activation potentiation and trying to potentiate muscle groups. The idea actually came when we went for our first competition in Tokyo before the Olympics, and it was a lot more closed then. So there was no access to gyms, there was no access to we couldn't bring weights or anything like that with us. So the idea became, could we use BFR to do that? So a combination of BFR and bands. And one of the things about the BFR is that you do increase your neuromuscular coordination as a result of using it. And so it was really interesting, because just doing simple counter movement jump, after doing that, we were able to demonstrate 2 to 3 centimeter increase just in the counter movement jump straight after. And then the counter move, we're just using the My Jump app at the time. It's just really simple, easy. You can use it anywhere. So that's become part of the post kind of our potentiation strategy. The good thing with that is that the athletes feel like they're getting a load. But you don't have the effects of when you would load in terms of soreness or anything like that after. So from a load management, from an activation point of view, leading to performance, it's been a good strategy. So post Olympics, during the Olympics, what I'll do, let's say with Tom in terms of the recovery, as soon as we finish, you know, the competition, it was straight back, and it was Winback, so techotherapy so for me, part of it was about, can we yes, it's recovery, it's maximizing recovery. In that instance, that whole you know, when they're talking about the effect lasting for 24 hours in sport, in a competition environment, that's perfect. You know, you want to do your release work, and you're timing it, knowing that actually they're going to sleep overnight. By the time they start competing, it's still they've got a raised kind of cellular metabolism. So in a sporting environment, that 24-hour effect becomes critical. And it's about leveraging it and sometimes piggybacking on it to double the effect, you know, when we can. And that's what we've done from time to time. So in the evening, it might be straight away after competing, we're starting that. If there's a 36-hour gap until they're going to do it again, then I might see them again in the, you know, when there's, you know, time that's convenient. It's literally, you know, 5 to 10 minutes almost to boost that same metabolism again, so that they're actually operating within that 24-hour gap.
Right. Okay, and Mickey, just for your question to that, that's the accessory that Gareth was talking about earlier.
Yep.
Megahertz. So we'll have a chat on that later. Okay, guys. Mickey, from your side, any further tips, questions, thoughts?
No.
You're okay. All right.